So I'm going to be presenting on behalf of actually a multidisciplinary team, and two of the members of the team are here today, Dr Janet Schloss, who's the chief investigator of our study, and Justin Sinclair, who's taking a photo just now. And I was very honoured to be involved in this research. I just want to give you a little bit of a background as to who I am and where I'm coming from. My background is in palliative care, and I have worked as a doctor now for over 30 years, and the last 20 years in palliative and supportive care. And as people started living longer with cancer and with more complex disease, my interest became in keeping people living well with cancer and looking outside of the box of what other tools we have or we may need in our toolbox to improve people's symptom management and potentially enhance the effects of some anti-cancer treatments. I'm a co-investigator on a New South Wales health study, the CARE trial, which I'm not going to speak about today, but it's a very exciting study once we get the ethics through. And although bioceuticals have sponsored this study, it is not a drug company study. And I have no financial relationships with any companies. Professor Chris O'Brien, it was the brains behind and the passion behind building the Chris O'Brien Lifehouse Comprehensive Cancer Centre, which opened its doors in 2014. In 2003, he was the director of the Sydney Cancer Centre. He was a head and neck surgeon. And his vision was that comprehensive therapies, complementary therapies are alongside of all standard therapies in cancer care, and to build a centre of research and clinical excellence. The reason I put this slide up and telling you about Chris O'Brien is that he was diagnosed with a GBM at the age, a glioblastoma multiforme at the age of 55. And although Charlie Teo, his neurosurgeon and the surgeon on our study, operated on him 5 times, he received radiotherapy and chemotherapy, he embraced all complementary therapies, he died 2.5 years later from progressive glioblastoma multiforme. This is a deadly disease, and it's the 10th anniversary of his death this year. I'm a clinician. And when I was invited to run the supportive care and integrative oncology service at Lifehouse, I was also soon after approached to be involved in prescribing cannabis for anyone who is not eligible for the trial, our CINV trial for cannabis and nausea and vomiting that we run at Lifehouse. And so I became interested and have learnt along the way and am prescribing, and I'm not an authorised prescriber, nor do I want to be an authorised prescriber, but I've prescribed for over 70 patients. And I'm learning as I prescribe, and my interest is unmet supportive care needs and in good research. The most common reason people ask about medicinal cannabis in my space, in a large cancer hospital, are 3. Refractory symptoms in advanced cancer patients, and in New South Wales, this is what we can prescribe for. Cancer and cancer treatment-related symptoms, including the people who don't qualify the CINV study, or complex pain symptoms or other symptoms related to the cancer for people who don't have terminal disease, and I can prescribe for this. But what I'm going to talk to you today is the 3rd reason people come and speak to me, and that's the cancer itself. Can cannabis control my cancer? One of the medical oncologists we met with the other day asked the question, well, made a comment, he said, well, what we'd really like to be able to do is give an answer to this question rather than just shrug. And we've heard from Jetty today that it's hard to get these answers. It's not simple medicine, it's complex, but it's fascinating. So I'm going to talk to you about glioblastoma multiforme, the high-grade gliomas and astrocytomas, and these are very rare cancers. They make up 1.3% of all cancers that we see. In the States, it's 12,500 patients a year. In Australia, it's just over about 1,500 patients a year. But the mortality rate is 4.6%, so in 5 years. People don't live with this cancer. And the treatments that are available haven't changed much over the years. We're still looking at surgery, radiotherapy, chemotherapy. There's this super device that you can wear on your head that puts electric waves through, and hasn't shown improvement as yet. And the anti-angiogenic drugs like bevacizumab or Avastin have been trialled but not shown to be of any benefit, and that was disappointing. So people are looking for drugs that cross the blood-brain barrier that may have an anti-cancer effect, and this is where cannabis is really interesting. And we've heard about the GW Pharma study, and we've heard about injecting cannabis directly into tumours that look like this. These are horrible tumours. These are highly malignant, highly mutagenic, disgusting things that sit in the cerebral, in the brain of young people. Young people, I'm in my 50s, so I'm young. It's young people. It affects people like me and you. These tumours often are also associated with a lot of edema, tissue edema, so there's this pressure on the brain that makes the effect even more significant, so people become steroid dependent. The importance of improving the quality of life of these patients is profound. This is from the European Journal of Cancer from 2015, a study by Broadbent et al., just looking at the survivorship in 2007 to 2011, and the stats are still very similar. This is the Kaplan-Meier curve. We know that, I don't know if I've got a pointer, but at the bottom line is the, oh, that's what happens when you press that button. The bottom line is no treatment, and the top line in green is surgery, chemo, and radiotherapy. So you can see at 18 months, less than 40% of people are still alive, and by 60 months, it's less than 10% independent of the treatment. There's a statistical significant benefit for combined treatments versus no treatment. More simply, this picture now, the Cure Brain Cancer Foundation puts it this way: we're making advances in cancer treatment around the world. We're really making it a difference in childhood leukemias, in breast cancer, in lung cancer, in colon cancer. We're keeping people living longer with stage 4 cancers. But when it comes to GBM, which is the bottom line there, less than 1 out of 10 people will survive for 5 years. The other reason that, the other thing for GBM patients is not just curing the cancer, but also improving the cancer-related symptoms. People with high-grade gliomas have symptom clusters. People with advanced cancers have symptom clusters, and these symptom clusters are treated at the moment. I'm a palliative care specialist by trade. We treat these with polypharmacy, and it's really interesting to look at where cannabis can fit in the space of managing the symptom clusters. And this is the GBM, or the high-grade glioma symptom clusters, where sleep disturbances, cognitive impairment, fatigue, depression are often occurring at the same time. And here is a really exciting, so now I'm going to talk about this very exciting study. And I'm delighted to be presenting this. Janet, who is the force behind making this study happen, all the amendments that needed to go through to get this through ethics, and the incredible recruitment process, which I'll talk about, has really put us on the map as far as getting some information about the tolerability of 2 different ratios of medicinal cannabis in patients with glioblastoma. This is a randomised double-blind clinical trial. It is not an RCT. This is being sponsored by Bioceuticals, who have given us some funding to do this first stage of this study. Justin, David Sibbett, Amy Steele, and Charlie Teo are the other co-investigators, and there are a lot of other advisors. What's really exciting about this study is late this year, October, November, the study opened for recruitment, and within 3 months we've completely recruited. The last patient is going through, has all 80, we aim to recruit 85 patients with assuming a 20% attrition rate. The attrition rate's about 13 to 14%, and within 3 months, 85 patients have been recruited, and 84 have been enrolled, and already some have completed the first 12 weeks of the study. So we're already starting to look at looking at our data and where to from here. So the purpose of this, it's very exciting. The purpose of this study was to investigate the tolerability and dose selection of 2 different strengths of oral medicinal cannabis oil. These are whole plant products in patients who have been diagnosed with a GBM or a stage 4 astrocytoma that as an adjunct to standard treatment, they needed to have measurable disease at the time of enrolling on the study. The methodology, a double-blind randomised clinical trial comparing the 2 different ratios, I can't actually see that, unless I'll stand over here, of an oral medicinal cannabis formula. And we're using an historical matched cohort as the control, where data will be retrospectively collected from the patient medical records and matched with cases for age, gender, disease, history of medical cannabis use during that time. So the primary objective, as I mentioned, is the tolerability of these 2 different formulas. These are whole plant products, and we have the full CBD and THC and other minor cannabinoid and also terpene profiles of these products. But it's the tolerability of the products by looking at specific quality of life questionnaires, the FACT-BR. But the secondary outcomes are really interesting, and the secondary outcomes and endpoints are really what's going to lead the way then for the next stage of this research. And that is to compare the effectiveness of the 1:1 CBD THC product and the 1:4 CBD THC oil on the progression-free survival in conjunction with standard treatment. So similar to the GW Pharma study, it's together with temozolomide or radiotherapy, surgery, lomustine and other products that are being used in standard treatment for GBM. We're also evaluating the absorption of the sublingual and the oral administration of the medicinal cannabis, evaluating the safety, because safety is really important to move to the next stage to be able to integrate the use of cannabis for these patients. You need to make sure that these are tolerated medication, these are tolerated products, and that they're safe to use. And so looking at the anticonvulsant levels, if they're measurable, not all are, and the toxicity, and if the adverse events are high. We get lots of contact from Janet, who's there on the floor flying in. It's a national study, so it's flying in to Sydney regularly and seeing these patients, and at any stage we are getting bombarded with emails to address each adverse event as they come through. There aren't many. Investigating a dose range for the oral administration and evaluating the impact of the medicinal cannabis on the quality of life and the symptoms of these patients. And that's really important in this space, in this group of patients with poor prognosis disease, with a prognosis of 14 to 18 months on average with treatment. And evaluating the cost effectiveness of using medicinal cannabis. So we're not saying, this isn't powered to be an effectiveness study, it's powered to be a tolerability study. But is there a signal for the impact on tumour growth? And so how do we look for a signal for the impact on tumour growth? So we're assessing the difference in the tumour at baseline and at 12 weeks using the RANO criteria with serial MRIs. And looking at survival time after the intervention, people will continue to be receiving cannabis until they die or don't tolerate it, withdraw for another reason. And so even after the 12 weeks, they'll continue to be followed up throughout until progression of disease. And so that we'll be continuing to follow them up over 2 years, perhaps longer, and they'll continue to receive the product. So the study design looks something like this. We have Group 1, standard treatment plus CBD, THC 1:1, and Group 2, CBD to THC, the 1:4 product. As I said, they're whole plant products. We have the details of the products there. It's not a drug trial. It's not a drug company trial. The drug company is supporting the trial. The dose is given just at night, and it's given, and it's gradually there. We've given people instructions on how to titrate the dose, and Janet's really behind the scenes of all of this, and the research nurse is contacting the family daily to help adjust and titrate the dose. And they're monitored regularly, and if the dose is too high, it's brought back down. The baseline scans, as I mentioned, week 0, 4, 8 and 12, pathology, bloods are going to be evaluated by mass spec. The quality of life questionnaires and other case study questionnaires are being performed, on these face-to-face visits. Now, people are flying from all over Australia to participate in this study. So they're flying in, so they have to be able to fly. And they come to Sydney, and but after that, they'll continue to have standard treatment in their home cities and be followed up through telehealth follow-up. And it's exciting. It's exciting that 818 patients applied to be screened for this study very rapidly. This is in a really short period of time. We're talking about 3 months? 3 months. And it was a lot of work. I didn't do it, that these guys did. 556 patients were excluded, and most of them because they didn't meet the criteria for eligibility, and there are close to 200 patients on the wait list who didn't get onto the study because we only could recruit to the 85 patients, and they have been recruited. They've been divided into, once they've been enrolled, then they go into we're blinded into which arm and which product they'll receive. And the ones that have been withdrawn are patients who have died, or one person who violated the ethics. And people die from this disease, and people have been enrolled late in the onset of their disease, and so it's difficult. And now we've got a few patients who have passed the 12-week mark. So it's a really exciting space to be working in. And now we're having discussions as to where to from here, because obviously we have a lot of data that we're going to be looking at and a lot of opportunities to take this further and to look at the next stage. I like to quote John Kabat-Zinn. I work a lot with prescribing other things besides cannabis, including mindfulness, exercise, diet changes, lifestyle changes, get everyone to do yoga, and have acupuncture and traditional Chinese medicine is a fascinating way of keeping people well and balanced with cancer. But when it comes to cannabis, I've realised that this isn't going away, and so you can't stop the wave, and we need to learn how to ride these waves. And as I said in the talk I gave the other day, I'm not getting back on a surfboard, but I'm really happy to stay involved in this space. Thank you.